Yes, 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 yes.
Hello, good afternoon. Hello, good afternoon, everyone. I'm Dr. Vijil Rahulan. I'm the additional director of Heart and Lung Transplant Institute at KIMS Hospital in Secunderabad. I am also have a large experience in heart and lung transplant over the years, and I will be talking about lung transplantation, how it has come of age in India with very good results. And we will go in detail about indications for lung transplant. That is, what are the patients who would benefit from a lung transplantation. I will also talk about um, what diseases which are commonly being referred for lung transplant in India. We'll also look at in detail about how the history of lung transplant in India and what are the results of lung transplant in India, how a patient with the end-stage lung disease can benefit from lung transplant. We'll also look at the newer indication of lung transplant, which has really brought it to the limelight, that is lung transplantation for COVID-affected destroyed lungs. So if you look at lung transplantation, this has been the one of the late entries of the other organ transplants. Like if you talk about transplant, you will always remember kidney transplant, liver transplant, heart transplant. These are all well-established therapy for end-stage disease of the organs. However, lung transplant, because of its severe complexities and multiple issues related to it, did not come into the public fore until recently. If you look at the history of lung transplant, the first lung transplant was done in 1963 in the US. Uh, but however, for many years, almost 20 years, it was not well spread and not many doctors were performing lung transplant. Uh, in the 1980s and 90s, there was various techniques which was refined, and lung transplant became much more accepted option for end-stage lung disease and lung failure. So right now, if you look at the worldwide statistics, about 4,500 operations, lung transplant, are performed in the world. And there are over close to 300 centers all around the world which do lung transplant. In India, the first single lung transplant was performed in Chennai Global Hospital, where I was working there in 2011. And since then, uh, it has become a more and more acceptable option with good results for end-stage lung disease and lung failure on patients who progress despite maximal medical therapy. And in spite of the whole medications, oxygen, supportive care, their symptoms are not improved and they are worsening day by day. These are the patients who will benefit from lung transplantation. So the indications for lung transplant, that means which are the patients who will benefit from lung transplant. Worldwide, if you see, COPD is the most common disease which is referred for lung transplantation. So COPD stands for chronic obstructive lung disease, which is a disease of related to smoking and smoking related lung damage. So in India, however, COPD is not the number one reason for referral. It is interstitial lung disease, that is lung pulmonary fibrosis, which is the most common reason by which we get referrals for transplantation. So in our series, almost 70% of our patients come from this category of patients. So we have experience of over 200 lung and heart lung transplants at this point of time. So our commonest referral is the subset of patients with pulmonary fibrosis or interstitial lung disease. But in the other parts of the world, COPD is the most common referral, followed by interstitial lung disease. Other reasons for by which patients are referred or who will benefit from lung transplant is cystic fibrosis or non-cystic fibrosis bronchiectasis, and also pulmonary arterial hypertension. So these are the most common causes of diseases that for which patients get referred for lung transplantation. So when do you refer patients? Let's say a patient has one of these diseases and they are on medications, they require oxygen. However, they are not improving. They are deteriorating day by day. Each breath is going to be a struggle for them. Their oxygen requirement is going up. They are getting other complications like pulmonary, high pulmonary pressures or pulmonary hypertension, or they have other issues like renal failure or weight loss or vomiting blood, hemoptysis. Any of these complications are happening, then they need to look at this option. So any end-stage lung disease patient, especially with interstitial lung disease or COPD or pulmonary hypertension or cystic fibrosis or non-cystic, non-CF or non-cystic fibrosis related bronchiectasis, uh, if they are progressing on despite maximal medical therapy, then this is an option. So when do you refer patients? This is for uh, the practicing pulmonologist who or internal medicine general practice doctors who see them. So if the lung functions, typically we do a pulmonary function test to assess the lung functions. And if the lung pulmonary function test is showing your lung functions are deteriorating by, like say, 10% in 6 months, or you are developing other comorbidities, other associated conditions, then you need to refer these patients. Typically, the most of the diseases, once your lung function is below 40%, then you can consider referral. One of the exceptions to this is that there is a particular disease called idiopathic pulmonary fibrosis or IPF. This is one type of interstitial lung disease, but it is a relentlessly progressing disease despite of therapy. If you are diagnosed of IPF, you need to refer much early because it is kind of a predictable course. Despite of medications, it is going to relentlessly progress. So eventually, most of these patients will end up in a situation where the medical therapy has failed and they look for options, and then transplant has a big role to play there. So if you have any of this disease, if you are on oxygen, and if your lung functions are deteriorating day by day, especially in the last 6 months, if your FEV1 is one of the parameters to look at, that is forced expiratory volume in 1 second. That is how much you can blow air after taking a deep breath. If that value is coming down by 10-15% every 6 months, and if your whole FEV1 or FVC is only about below 40%, then you become a candidate for lung transplant and you need to be referred. So once you have these diseases where um, you are not improved with medical therapy, then you get yourself referred to a lung transplant center. Obviously, once you get into the center, you need a complete checkup whether you still can undergo this transplant. So you have to get a lung transplantation workup where you look at how severe your original disease is, how any other comorbid conditions are there, if you have any undetected cardiac disease or undetected kidney disease or any other disease or other malignancies. So that is essential to have a full workup before you proceed this route. So you will have a full workup where you check for the severity of the disease, any comorbid conditions that you have, like cardiac diseases, and you look at how soon you want to have a transplant, whether you can wait a little bit or whether your body needs to be optimized more by physiotherapy so that you can undergo a transplant. So all these things are assessed during the workup, where you get a battery of tests to assess all the general systems in your body, and then we have a transplant meeting where we discuss each patients who are referred, and then final decision is given to the family, basically. So in the nutshell, if you put any chronic lung disease, oxygen dependent, progressing on medical treatment, uh, should be referred for lung transplantation. And you also look at what is the risk of death if you don't get a transplant before referral. So if you have end-stage lung disease and your life expectancy is uh, you are only expected to live for about 2 years. Those are the patients who most benefit from transplant. So that is one of the things we assess the severity of the underlying disease before we determine whether a patient is requiring transplant or not. So that is where the consultation of a transplant pulmonologist is important, and the whole team discuss about how severe is this patient. Is this patient will benefit from transplant? Because the two most important advantage of transplant is that one is it will give you life expectancy, and another most important thing is it will give you a better quality of life. So these are the two advantages transplant offers. Everybody knows that lung disease is a very difficult disease to have. Each breath will be a pain for them. So they are always reminded 24/7 that they have a lung problem and they are limited and they are not able to do their daily activities. They are requiring oxygen for any effort. So their quality of life in end-stage lung disease is very poor. So this is an option to give a better quality of life for these patients. So definitely, once you undergo transplant, you will not require oxygen. You can do uh, daily activities as almost like a normal person. So quality of life improvement is as important a advantage as the prolongation of life expectancy. So if you look at transplant, unlike other organ transplants, say kidney transplant, liver transplant, life expectancy for these transplants are more than 10 to 15 years. However, lung transplant, because of the various issues pertaining to the lung and the uniqueness of the lung, the life expectancy is less compared to other organ transplants. One of the reason is because lung is a very immunogenic organ. It has got a lot of lymphoid tissue. So the amount of anti-rejection medicines required, immunosuppressive medicines required is very high, which can lead more side effects like infection. The other reason is that lung is the only organ which is exposed to air all the time. So all other organs are protected inside the body. However, lung, with every breath you take, it is exposed to outside air, which contains a lot of microorganisms, irritant chemicals. So you are always, exposed to outside air, and there is always higher risk for infections. So because of these two reasons, the life expectancy of a lung transplant is not as good as other organ transplants, and this is one very important thing to remember. So the average median survival, as they say, uh, is uh, uh, is almost 8 years, which is an average. It can be more, it can be less, but this is less compared to other organs. However, the quality of life is much better if you don't have a transplant and if you are expected not to live for more than 2 years because of the severity of your disease progressing, because of other complications that disease is causing, then that justifies a lung transplant. So if you look at the benefit and risk as well as the improved quality of life and improved life expectancy, this is an option for selected patients with end-stage lung disease. So that is one important thing to remember. So there is also a concept of a transplantation window, because each organ, there is a life to it. It's not going to last forever and ever. So you have to do the transplant at the right time. You can't do it too early when you are able to do your activities with some help with oxygen. Because if you do it too early, then this benefit of more life and quality of life may not be as good. Or if you are too late, like you are very bedridden, your muscles are wasted, you can't even step out of bed. In that situation, to do any major surgery will be a challenge. You have a lot of issues, immediate post-operative issues. So you have to be evaluated and sent for transplant at the right transplant window. That is when the referral which has to happen early rather than very late. So in India, one of the issues is that referral for transplant happens very late when the patient is almost fully bedridden, they have lost a lot of weight, their muscle mass is less. So the transplant window is almost shutting for them. So we don't have time to optimize them to improve their physical condition and to have a better outcome. So if you are having a patient who is requiring oxygen but is able to get out of bed, walk a few steps, and is able to be more, having a rehabilitation potential by which you can improve their function, those are the best patients for transplant. Not when you are requiring very high oxygen, where you are bedridden, then you end up in the hospital emergency room, or requiring other invasive respiratory support like ventilator or even ECMO. So if the referral comes early, you do workup early, you do evaluate all the organ systems, and then you can improve the organ, the function. You can do pulmonary rehabilitation, improve the functions, then go for transplant. So that is the ideal scenario where you get maximum out of it, maximum success rate. However, in India, this is sort of a minority patients. Most of the patients end up referred when they are very advanced stage. They are almost on a non-invasive ventilator, or on a ventilator, or even worse, the lungs are failed and they are on an extracorporeal life support system or called ECMO. So these are not the ideal patients for transplant. However, we do transplant these patients because there is no other option for them. Either this or it is certain death for these patients. So these are modalities where we call it as a bridge to transplant. So we just support their life functions so that they can be registered for organ as an organ recipient and can get the lung. So the bridge to transplant, there are various modalities, of which ECMO is the upcoming modality, which we have seen a lot of patients during the COVID outbreak. So, however, if you look at any transplants without this requirement of this bridge to bridge, those are the best candidate for transplant with the best results. So early referral is important. Uh, how do we? What are the different types of transplant available? So there are different types of transplant. One is a single lung transplant where you just change one lung, and other is a double lung transplant, and then the third type is a heart and lung transplant. So single lung transplant can be done um, in certain diseases where both the lungs are affected, in where there is no infection related etiology, like it cannot be done in bronchiectasis or suppurative lung disease patients. where you just change one lung, but other lung is infected, so that will infect the new lung. So can be done in fibrotic patients, can be done in COPD. So you just change one lung. It can also be considered in older patients, especially more than 70 with less with a lot of comorbidities. It's a quick in and out surgery. So we select older patients who has a non-infective etiology for single lung transplant. But the most common performed surgery is a double lung transplant, simply because you are giving more lung tissue to the new recipient, and it will last longer than a single lung transplant. So double lung transplant is a preferred transplant in the most of the occasions, and should always be preferred over a single lung, especially except in these other circumstances when they are older, they have comorbidities, and they may not tolerate a double lung transplant. Obviously, it is a longer surgery. Initial postoperative recovery time may be longer than a single lung transplant. You do various incisions. One is a long incision where it's called a clamshell incision from one end to the other. The other option is a sternal sparing incision where they don't cut the breastbone or the sternum, and there will be two anterolateral thoracotomies to do the double lung transplant. And the third type of transplant is heart and lung transplant. This is um, indicated in patients who have heart disease as well as lung disease. So they have a congenital heart disease, which has caused high pressure in the lung, pulmonary hypertension, and then lung irreversible changes in the lung. Or they have pulmonary arterial hypertension, where there is high pressures in the lung, and it affects the right ventricle. There is ballooning of the right ventricle and right ventricular failure. Uh, so these are a specific subset of patients who will require a heart lung. But the most commonly done surgery is a double lung transplant, and this has the best results, long-term results, compared to the single or heart lung transplantation. Um, so the other thing I would like to discuss is the importance of a pre-transplant evaluation. So as I said, if the patient is referred early, we have time to improve the condition of the patient. So we admit the patient for about 4 or 5 days, do a lot of testing to find out how severe the disease is, and also to find out any other hidden diseases are there, or extent of the comorbidities, as we say. That is, what other organs, if there's any affection, uh, uh, which can complicate the surgery. So one of the things we look for is any contraindications for transplantation. That is, who should not get a transplant, or who has a relative contraindication. That is, some things needs to be fixed before he goes transplant. So one of the most common absolute contraindication is a malignancy, where is there any cancer, active cancer. So those patients are not generally candidate for transplant, except very specific malignancies like skin cancer or very localized cancers. Because after transplant, you generally suppress the immune system of the body, and this can cause flare up and very fast progression of most cancers, leading to a bad outcome. So malignancy is a absolute contraindication for transplant. Uh, then there is a lot of other contraindications which I will mention briefly. If you look at age, that is one of the commonest questions that patients ask, that he is too old for transplant. So if you look at the guidelines by the International Society of Heart and Lung Transplant, they have updated their guidelines. Earlier, they used to say more than 65 is high risk. Now, almost 30% of the transplants done in is of patients who are more than 65. So the age cutoff is a relative contraindication. Preferably, um, uh, we do patients who are lesser than 70 years. However, there is no limit for age. If they are in good shape, we can do even up to 75 years of age, which is getting more and more common in the West. The most eldest patient we have done is 74 years with good outcomes. So age is a relative contraindication. There is no upper limit of cutoff. It all depends on how fit the recipient is, how we feel that he can tolerate a transplant surgery. The other relative contraindication, or which issue which needs to be done dealt with in the pre-transplant workup, is coronary heart disease or heart-related issues. So most of these patients have, especially if they are smokers, they will have um, cardiac issues like heart blockages in the coronary vessels. So how do we deal with this population? So this has to be fixed before transplant or during the transplant. So in our workup, we mandatorily do a coronary angiogram to see if they have any heart blocks, and either you have to be fixed. We have this fixed with a stent before surgery, or if possible, a bypass surgery will be done along with the transplant. So this is a relative contraindication. It can be fixed during surgery. So we have done about 7 cases with concomitant bypass surgery with lung transplantation, and it is an accepted mode for patients with coronary heart disease and lung disease requiring transplantation. We'll also have to look at other organs, like if there's any renal failure, any liver failure, it has to be carefully evaluated. Like patients who have COPD and who are alcoholic, who has liver disease. So these has to be checked very carefully, and also patient with kidney disease and lung disease, whether they are candidates for double organ transplant or whether they are too high risk for a transplant. So these are things. Double organ transplant, multi-organ transplant is not very common, but it is definitely increasing as many centers get comfortable doing. Obviously, there is more risks involved. However, that is also an option for these patients. And then infections. So we would like our recipients to be not having an active infection before going into transplant surgery. So this is one thing which we carefully assess. We do cultures of the blood, urine. Sometimes, if required, there will be a bronchoscopy, lavage to be taken from the lung to see is there any active infection going on. So there are some organisms which are very difficult to treat and very difficult to be eradicated. So they also form a relative contraindication, or something which needs to be fixed before going into transplant. So there are some multi-resistant organisms like Burkholderia or very drug-resistant organisms, or Mycobacterium abscessans, and then some Secnosporidium, some fungal infections. All of this is very difficult to treat, and hence we need to be sure that they don't have an active infection. For Indian context patients, we don't prefer to have an active TB infection. If they can wait till the initial 1 or 2 months for the initial TB treatment and to get control of TB, that can be done, and then patient can undergo transplant. So these are just the relative contraindications for transplant. The other thing is they should be stable psychologically. They should have a good social setup. So that is very important because they should have a caregiver, and at least, and they should have a good support system at home, and they should be having a very stable psychological balance by which they will take these immunosuppressive medicines after transplant. If somebody is non-compliant with medications, or they are a substance abuser who doesn't take medications, who are not interested in compliance of medicines, then they are not a candidate for transplant. And also in the Indian setting, obviously this is it involves a financial aspect as well. Sometimes post-transplant medications will have these are sort of expensive medications also. So they need to have that backup as well to have a long-term good outcome as well. So these are the some of the things with the pre-transplant evaluation will address. So once you do the evaluation, you assess all other organs. You try to fix them. If there is something which has come up, like coronary disease, we fix them, or if other organ failure, we can try to improve. And then we try to put them through a rehabilitation program by which we improve their muscle strength, improve their respiratory capacity, and improving their walking distance so that they become a better candidate for transplant. This all can be done if they are referred early. However, if they are very sick and they are almost on ventilator or on other supports, all these can't be done, and that will have a bearing on the outcome as well. So, pre-transplant evaluation, pre-transplant optimization, pre-transplant rehabilitation, these are extremely important for a very successful lung transplant program. If you come in very late, if you're coming in other supports or bridges transplant, then you need that much more time to recover. You know, you after surgery, if you look at it, is unlike other transplants, like a heart transplant, where surgery, if you have a good uh, surgical good surgery is done, almost 80% job is done. The rest 20% is just ICU care and recovery. However, in lung transplant, a good surgery maybe amounts to only 30-40% of the whole thing. Because they are in a very bad shape and they are having a lot of comorbidities, uh, the post-surgical recovery time, especially the critical care time in the ICU, is very, very important. So whenever after the surgery is done, we have to immunosuppress them. That means the new organ, when it is put to somebody else's body, our body or the recipient's body tries to mount an immune response to that because it tries to recognize it as a foreign object and then try to attack. That's how everybody's body reacts to an external stimulus. So the immune system uh, tries to attack this lung and tries to mount a response, and this can damage the new graft. So everybody has to be immunosuppressed for this transplant organ to function. So when you immunosuppress somebody who is already having some unknown infection or um, was not properly rehabilitated, uh, they have a recurrence of infections, other side effects can happen, and then their post-operative recovery becomes very slow. So they have much more time on the ventilator, very difficulty coming out of ventilator, and the more time they spend in the ICU, more infections there. The risk of infections are more. So their outcome and complication rate are also not that great. So if you prepare well pre-op, good rehabilitation, then post-operative recovery becomes very fast. You are out of the ICU in a week, and typically they stay about 2 weeks in the regular room, and then they go home in about 3 weeks' time. So that is the usual circumstances. However, if they come on an ECMO or a ventilator, they are very deconditioned. Then these 3 weeks can become even 3 months. So it all depends on how the shape of the patient is when they are going into surgery. Sometimes they are very sick and you don't have time. because they can't do any rehab. They are already on 30, 40 liters of oxygen. They are on a ventilator, they are on ECMO. So then there is no other option. We have to accept a higher risk and then go ahead with the surgery, because if there is no other option, no survival is possible, then that risk we have to accept. So how long is the surgery? I just talk about briefly about um, the transplant surgery. So single lung transplant is just one lung change. Double lung transplant is sequentially both lungs will be changed. So the incision is made in the main bronchus. It's not usually made in the trachea for double lung transplant. First, the worst lung is removed, and then during that time, the other lung take over functions, and then the new lung is placed, and then the other opposite lung is removed as in a sequential manner. And then in heart lung, obviously, heart and lung is removed, and a new as an end block, and both are removed, and new heart lung block is placed. So typically, a single lung operation lasts about around 4 hours or so, and a double lung surgery can last from 6 to 8 hours, and a heart lung also is about 4 to 6 hours. Um, so there is something called ischemic time. That is, in India, um, most of the donations are from brain dead. Almost all are from brain dead donors. We don't have a circulating dead donors, because as in the West, which DCD donors account for about 20%, 20, 30%. So when a donor becomes available, that hospital notifies uh, the government agency, which is different in different states. And then there is also a national agency called NOTO, that there is an organ available. So once that notification comes, the state agency, the organ transplant agency, notifies the hospitals where the recipients are listed. So, and then they look at the seniority of the listing, and then they allot organs based on the seniority, as well as, of course, other considerations like blood group and size matching of the recipients. So, all of these are considered while determining who is the best recipient for this particular donor. So, in India, the preference is always given to hospitals who are generating their own donors. If they have a recipient in that hospital, they will get the preference. If they don't have that recipient of that organ, then it will be given to the common state pool. So donations, unfortunately, if you look at the Indian condition, it is very less compared to other countries. So in India, probably the rate of donations is unfortunately very less. So that is, organ donation is a very important and almost a godly act, I will say. And we need to promote organ donation, because without organ donation, the transplantation is a very difficult and impossible task. So I'm thankful to the government of Telangana and most southern Indian states, where there is a culture for organ donation. If you look at the organ donation in the country, the Western India and Southern India account for most of the organ donations. In North India, unfortunately, the awareness is less, and organ donations are less. So, so once the donor becomes available, the hospitals get notification about it, and then you need we send our retrieval team. They go there, they inspect the organs, and they may undergo a very meticulous inspection of the lung, by which you do a bronchoscopy, you make sure there's no infections, you test that fluid, you do a wash of the lung, see if there's any infection happens, uh, and also you look at the CT scans, X-rays, or the cultures to look for any problems that their lung may have. Because the donors are road traffic accidents. So whenever there is a road traffic accident, lung is a very commonly affected organ because they may get thrown around and they have fractures of the ribs. They may have leak in the lung. Some contusions or trauma to the lung can happen. So we look at that very carefully. Once we are satisfied with the radiology part, that is the CT scans, X-rays, bronchoscopy is done. If you also look at if there's a lot of pus inside the lung, clean up the or collected blood in the lung. So you clean that out, and then they look at the lung functions. So um, we always check what is called as a blood gas to look how the lung is functioning, how much it is able to oxygenate the blood. As you know, the function of the lung is to oxygenate the blood, that is to get oxygen from the air to the blood and to excrete carbon dioxide from the blood to outside. So you look at the blood gas and see how much the lung is able to oxygenate. So if the lung is oxygenating well, if the X-rays and CT scans are good, and if the bronchoscopy is not showing any signs of infection or a lot of contusion, then we deem that lung to be good. And then we send a notification to the state agency that we are ready to accept the organ. So as per the seniority, the agency will allot lungs. And then once that is done, um, so you have to complete the surgery within the shortest possible time, which is called the ischemia time. That is the moment the lung is removed from the donor till the lung is attached to the recipient. So most of the time the lung is retrieved and then they are put in an ice box with special nutritional solutions. The commonly used solution is called Perfidex in multiple bags packed in ice boxes and then shifted. So the lung, during that shifting time, there is no blood going into the lung. And the temperature is cooled so much that the metabolism of the lung is slowed so that the death of the lung doesn't is slowed down. So that lung is in a suspended animation state where things are all frozen and stopped. So that time should not be too long. If it is too long, then the irreversible damage happens to the lung. And then when you put it into a new person, the lung will not function immediately. So that is called as a primary graft dysfunction. So if the lung is not working, then uh, the initial time it may need help. So you may need a extra, longer ventilation time, or sometimes you may need ECMO, which is artificial lung support. So till the time the lung starts working well. So primary graft dysfunction is more when you are taking a long time to do the transport and of course the surgery aspect after that. So you have the recipient has to stay in the same city where they are going to get an operation. You can't just like say in other organs like liver, you don't necessarily need to stay in the same city. You can come with the next flight because the ischemic time of the liver is very long. But in the lung, you have to be within that 6 hours time. So you have the recipient has to wait in the same city as the transplant center in order to get the best outcome. So once the retrieval is done and then surgery proceeds, and then we always try, and it's like a clicking clock, ticking clock. So once the lung is removed, the clock starts ticking. You have to finish everything by that 6 to 8 hours. Nowadays, there are newer developments in this. Instead of the cold ischemic transport, now there are warm uh, ways to transport the lung. There are various new organ care systems available where blood or nutritional fluid is circulated during this transport. So the lung need not fit into this 6 to 8 hours. You can take 10 hours to 12 hours. And also you can bring the lung, put it on this special machines called XYO system, you can improve the quality of the lung. So these are things which are going to come in a big way in the next decade or so. So the ex vivo system we are soon to start in our center, which will enable us to take organs from anywhere in the country, and the ischemia time won't be a constraint anymore. So once the surgery starts, um, as I said, it depends on the single lung, double lung, or heart lung, the durations I've explained. And now let's look at what are the commonly encountered complications of surgery. So if you look at the success of or lung transplantation in India, the success is based upon the years of survival, basically. So there may be a 1 year survival, there may be a 3 year, 5 year, and 10 year survival. Obviously, the length of survival is less compared to the other organs. The 1 year survival is what the most is the gold standard of as, and then there's a long-term 5 year survival. So 1 and 5 are the most common parameters that people look at. So 1 year survival is our in our program is about 82%, and in worldwide, if you see, it is always between 80 to 90% in even in the Western countries. The 5 year survival average is about 60%, and 10 year survival is about 40%. So as the time goes long, uh, the body's response to the lung happens, and the lung functions gradually come down. So there may be a rejection, which is called an acute, which is when it is very early in the time, or it can be a chronic, where the body gradually gets to know that this is a foreign lung and then mounts a response, and gradually the lung function fades off. So rejection happens to um, all the lung. How we deal with it and how we can maximize the survival, that depends on the how closely we monitor it, and how aggressively we treat if we detect rejection. So the post transplant care is always a balance between rejection and infection. These are the two main issues after transplant. So any of the transplanted lung, if they want to survive in the recipient, you have to give immunosuppression. Otherwise, your uh, body's immunity, the recipient's immunity, will attack the lung. So how we do it, that is why we have a large team who monitor these patients on a daily basis. So that is extremely important. This surgery, unlike any other surgery, transplantation is not a one-time thing. You have to have the support and um, the persistence to follow a very organized and a life post-transplant, where all these things are always, you have to be aware, certain things has to be followed, so then only you will get a maximum out of it, because you already have a finite lung function. If something happens, some rejection episode happens, or if an infection episode happens, and you lose lung function, it's not going to come back, because it is not the recipient's own lung, it is somebody else's lung. So you have only so much function which is there. So the complications of transplant, most common is the rejection, where the body tries to mount an immune response, and then and the immune response, meaning it can be a cellular rejection by means of a T cells, or it can be an antibody mediated, which is also a different type of response. So it can be acute, where it happens immediately, or it can be chronic, where it happens over the years. So post transplant follow up is always about how to detect rejection early, and then you treat it by improving the immunosuppression. So you give medications that will suppress certain subsets of the immune response, certain arms will be blocked, and that rejection response will then subside. So you have to keep monitoring them, and one of the best way to monitor them is to do periodic bronchoscopies. You do a do a bronchoscopy, take a small microscopic piece, and then check for if any rejection is happening. So, so the success of a transplant is always will depend on close monitoring. So in the first year, we do bronchoscopies in the first month, third month, 6 months, 12 months. And after that, every 6 monthly to monitor for rejection. So whenever there is rejection signs which we see on the microscope, immediately we give treatment for it, depending upon what type of rejection happens. So the cellular rejection is easier to treat. It is responsive. We have good success with it. Most of the patients will have about 20-30% will have at least one rejection in the first year. So we do these surveillance bronchoscopies in the first year because that is when the maximum rejection happens. Once the 1 year is over, then it is kind of a stable response. Then you have to just look at the chronic aspect. In India, we have one of the problems that we face is our recipients are not as diligent in monitoring to various reasons compared to the West. One of the main reason it may be because of the financial issues. However, that is something that we need to be upfront, have a long discussion that sometimes patients think that everything is fine, I don't need to worry about it, so they let their guard down, and that is when suddenly an infection or rejection event happens. And once that happens, even if we treat, you lose lung function. So once the lung functions go, then it doesn't recover back. So then you have to live with a lower level of lung function. And then we try to treat it and make it stable so that it doesn't progress more. But what lung function lost may not recover fully. So that is something you have to be vigilant throughout the life. You should not let their guard down. I'm not saying this to scare patients, but this is what the reality is. You have to wear masks so that you protect against infections. If somebody else is sick in the household, we need to segregate them. So the more you take care of the lung, the longer it's going to last. It's as simple as that. So the success rate in India, that our program was started in the current form 3 years ago. So we have just accept 1 year publication, 1 year success rates have been just accepted for publication, and it's about 82%. 3 years survival is just going to be, we are just compiling the data, and we will hope to publish it soon. But however, it will, we are confident it will be in the range of 75 to 80%. So the longer term data in India is currently not available in most of the programs. However, in the West, if you look, 5 year survival is close to 60%, and 10 year survival is close to 40%. So that is how the success and the longevity of the lung transplant is. However, uh, in the current scenario, COVID has brought a lot of changes in it. I mean, people are not willing to travel for um, um, these follow-ups, biopsies. So it may the impact of COVID in the follow-up is something that we have to wait and see. We have changed the follow-up to a virtual mode now. We collect data from the patient each through WhatsApp and other um, apps, and they send in that their lung functions, and then we keep monitoring them. Any drop in functions, then we call them, we do the biopsy, and see if there is something wrong with it. Other thing in India is the high rate of viral infections. So because of the density of the populations, the rate of viral infections also high. So respiratory viruses is also a very important reason why uh, the longevity of lung transplants is affected in our country. So one of the commonest respiratory virus before this COVID is there is a group of community acquired respiratory viruses like adenovirus, influenza, parainfluenza, uh, and rhinovirus. So this is very common in the country. Whenever you have a viral infection, it activates the immune system. So whenever immune system is activated, there is always a rejection response. So infection almost always will have a rejection response, which may affect the transplanted graft. So infection rejection has to be carefully evaluated and treated very early so that it doesn't have a lasting effect on the graft. Other side effects or other things to look forward is that because we are suppressing the immune system, there are issues like there is also a slight increased risk of malignancy in these patients. And the immunosuppressive medications can have side effects. So the immunosuppression medicines, there are mainly four drugs. One is called tacrolimus, the other is mycophenolate, and steroids and mTOR inhibitors or everolimus. So these are the four major class of medications used. All of them will have its own side effects. So side effect monitoring is very important. Most of the post-transplant patients will be on 10-15 medications post-transplant. So there will be immunosuppressive medications. There will be medications to reduce the infection. So antibiotics will be there by inhaled form, antifungal will be there, inhaled form or tablet form, antivirals to against CMV virus, other viruses. So there will be a lot of medications to take, but there is no other option for them. These are all to protect them and to help the lung last long. So unfortunately, this is expensive. So that is when the social support, the financial support has to be there for these patients to live much longer. So immunosuppressions, suppressive medicines have side effects, so that needs to be monitored, especially kidney functions, liver functions. So they will, especially in the first year, they will need to be monitored very closely every week, every 2 weeks, or every once a month, like that. So post-transplant care is as important. We have to be monitored closely. There are a lot of programs in the country where once this um, surgery is done and patient goes home, then there is no good follow-up. So I would like to stress that the success of a transplant center is always to get the patient back to becoming a productive member of society and keep the patient there. So in order to do that, you have to have a good, robust monitoring system. Without that, you can't expect a longer life for these patients. There will be invariably some problem happening because the patients are not going back to a vacuum. They are going back to the community where there is, pollution is there, there is infection is there, and so many things can affect the lung because it's always exposed to the air. So you need to take precautions, and it has to be continued. One of the common things that patient ask is, doctor, how long I have to take this immunosuppressive medicines? Will the body accept the lung? So unfortunately, in the lung transplant, it doesn't happen at all. You have to take immunosuppressive medicines throughout the life. After 1 year, we will reduce the dose, but we will not be able to stop immunosuppression. Or it's unlike other organs like liver, which is not a very immunogenic organ. After a few years, you can reduce immunosuppression to a major degree. In lung, it is a very immunogenic organ and it's exposed to environment. So there is no way we can stop immunosuppression, because the moment you stop immunosuppression, either rejection will immediately happen, and it can happen within a few weeks time. And once rejection happens, the treatment is always a problem. So prevention is the best method. You have to follow a regimental system where you monitor things closely. You have to have certain safeguards. You can't just walk around in dusty places and play in, go to environments where you are likely to get infections. So you have to be on your guard always. If you're at home, you don't need to wear a mask all the time. You are free to do whatever you want. But when you go out, especially to dusty places, you have to take protection, because once you get an infection, treating is always second best rather than preventing. So that is something we need to be very aware of, and we need to think about it before getting transplant surgery. The other thing is the COVID scenario. So COVID has brought a new indication for lung transplantation, which has been one of the reasons why lung transplant has become a focus in the current scenario. So COVID, unprecedented event in the history, and it has an affinity to the lungs, and lungs are the most commonest organ which is affected. So COVID causes severe destruction of the lung. It can cause accelerated fibrosis. It can cause small microthrombi in the lung. It can destroy the alveoli and the alveolar epithelium, and the repair is not as good. So there are multiple processes going on at the same time. The epithelial damage, the thrombotic events, the fibrosis that happens. So most of the patients will have a combination of all three factors. If the initial damage is so severe, they are on the ventilator and not improving, uh, then they may need an ECMO support. Some may improve, some may not improve. So if you determine that the lung is totally destroyed, totally fibrosed, chances of recovery is very less, then only then the transplant is a role in these patients. So there are now guidelines which have been formed in the international level. You have to wait at least 4 to 6 weeks on a respiratory support, be it ventilator or ECMO, before considering this option. You should not have any other organ system problem. So you should not be on dialysis, you should not have a kidney problem, you should not have a liver issue. So it should be a single organ dysfunction. Only then we can consider transplant for these patients. Then number three, there should not be any active infections. Number four, the patient should be awake and able to participate in some rehab, possibly before transplant procedure. And so if these and they should not be too old as well. So because the older patients, the lung repair is less, more comorbidities, success rate may be low. So these are a very specific set of or patients who would benefit from transplant post COVID. So usually transplant happens after when there is no recovery, absolutely no recovery possible. Usually after 4 to 6 weeks on respiratory support, and then obviously they are on a respiratory support requiring high oxygen. Then on, so we can't do much of a rehab for them. So some patients they shift. Most of the patients are on ECMO when we attempt these. Some are on very high flow oxygen requiring 50, 60 liters of oxygen per minute. So we have done about 10 patients post COVID, and with 80% survival on them. So, however, these are extremely difficult patients because there's no rehab. They have already received multiple agents to modify their immune system, like tocilizumab and other modalities, where the immune system already has been affected. They already have multiple infection rounds in the other hospitals before they come. So these patients, they behave, they are an extreme set. However, when there is no other way out and the alternative to transplant is a certain death, then and they fulfill the other criteria like age, organ failure criterias, then these can be done with an acceptance that we can't offer that 80% money survival to them. Survival may be less than that for sure. And they will be in the hospital for many months before they can walk out home. So once those are explained to the family and the risk and assessment is done, then they can be candidates for transplant. So typically these are done in experienced centers who has good experience in ECMO management and good experience in dealing with um, transplant in general, because they are higher risk patients and the survival is not as good, and they need take a lot out of the team to because they recover very slowly. They are at risk for multiple infections. The rehab has to be done over time. Nutritionally, they are depleted. So post-COVID fibrosis with no recovery is the newest indication for transplant. However, only in very selected patients and with good risk-benefit discussion with the family, basically. And one more thing I would like to mention is uh, the quality of life. That is one of the major advantage of transplant. So any lung disease who are progressing with maximum medical therapy, they are on oxygen, they are bed bound. So they have a very poor quality of life. They are always reminded and they are limited. So lung transplant is an option for them where they are able to live a near normal life. Once they get out of the hospital, they will no longer need oxygen. They can do most of the activities um, on their own. However, as I said, or they need to take the precautions and follow up regularly. In those cases, the quality of life is excellent. So this is one of the major advantage for lung transplantation. So we have patients who have undergone transplant. They travel around the world with precautions. This was before the pandemic, of course, and some have participated in half marathons, paragliding, and other activities. So as you can see, transplant offers survival advantage as well as quality of life advantage. It offers a hope for patients who have end-stage lung disease with nowhere to go. In the past, they all used to die a very miserable death, but this is an offering a beacon of hope for them for a second innings of their life. Obviously, you can't replicate 100% normal life for them. However, in the circumstances, this is what the best we can offer as of the cutting edge medical technology, and only with the support team, dedicated professionals to monitor them, and of course a family member support, then all of this, if it comes together, then they have a very good outcome, a very fulfilling time uh, post transplant. So I will take some questions here and see if so one of the questions is related to age. So is there an upper limit of lung transplant can it be performed? So as I mentioned earlier, is that age is not a um, absolute contraindications. More and more elderly patients are doing um, have successfully done transplant. Anything, there are some studies show that more than 70, they have a slightly lesser long-term survival compared to below 70. However, it all depends on how functional the recipient is, how he can be rehabilitated. So age is probably just a number. It all depends on the
Hi,
current status,
from the
the
Hibis.
health status of the patient. Um, So, so I would like to thank our team, our program chair, Dr. Sandeep Atavar, the KIMS Hospital uh, management team, for giving me this opportunity to talk extensively about lung transplantations, the indications, the complications, the life expectancy in India, the issues related to transplant, and I hope that I have tried to explain all these factors to the best of my ability. Thank you very much.